I'd like to invite each of our panelists, Carol, Barbara, Stephanie, Kamlesh, and David, to come to this virtual podium by switching your camera on so everybody can see you. And we will address a question to each of you. You can also ask questions if you want to the other two speakers. But let me take the privilege of chairing this session by asking both Stefan and Abd about, more specifically, when we speak about diabetes and viral infections, Stefan, we always think intuitively that a virus could cause damage to the pancreas, and most likely that leads to a type 1 form of diabetes. Now, given the data you presented with the various different organs that actually the virus can affect, do you think there is a risk potentially here that rather than just type 1 diabetes, there may be a different type 2 diabetes or perhaps even a different form of diabetes that this type of virus can cause?
I think we probably will see different mechanisms. So astonishing are those results that type 1 diabetes seems to occur. It's a small number so far, destroying islets without anti-autoimmune, with a typical autoantibodies. So that is a form of a post-infectious diabetes, probably that we have seen with other viruses. Of course, it's not unusual. It has been described for SARS, as you know. Definitely, the mechanisms, if it's direct on the beta cell or the surrounding cell or the inflammation locally, we don't know yet. There is certainly the notion that type 2 diabetes that was maybe a pre-diabetes through the inflammation and through the hampering with these anti-inflammatory, metabolically positive AC2 pathway, may then shift to a full manifest diabetes type 2. I don't think this is the same. I mean, it's probably different mechanisms that will occur. I'm looking currently at a very interesting case of a patient that was defined as a LADA. I mean, we are now going away from using this term. A lady almost 80 years old, all of a sudden develops, following COVID-19 infection, very slim lady, type 1 diabetes, but mild. It turns out that she had autoantibodies. So it is possible in this case, very different from the other case that I described, that she probably all her life in the family had these autoantibodies, but it didn't do her any harm. And now came the COVID-19 and she shifted into something like a mild type 1 diabetes. So it will be interesting. We don't know at this point, really.
Work in progress there. Kamlesh, may I ask you you're part of the COVID co-investigators that have recently launched this international global registry to try and understand exactly what form of diabetes we're dealing with, or how frequent it is, this phenomenon of new onset diabetes, and also how frequently COVID can actually cause severe metabolic complications of diabetes. If you have to make a bet based on what we know so far, what do you think is going to be the size of this problem? And again, what do you think is going to be the biggest challenge that COVID could cause in terms of diabetes management?
Okay, well, first of all, thank you all for inviting me to this fabulous conference. Now, in terms of what Stefan said, I think the type 1, in terms of destruction of beta cells, is going to be a rarer form. But what we've seen from hospitals here in the UK, and there's some data from France that's been presented already by, is that these patients do seem to go into insulin resistance when they go into hospital. Severe insulin resistance. We don't know what's associated. We know there's this cytokine storm that occurs, and they then are diagnosed with diabetes once they're admitted. So I think we're going to see two possible forms of diabetes. One is the type 1, with no beta cells at all, complete lack of insulin secretion, and the other group are admitted with severe disease who then come out. They're being admitted needing insulin. They've never had diabetes before. And we're just wondering, are these people who may have had pre-diabetes before and they weren't detected beforehand? As we know, many of these are obese. The databases are showing anything from 40 to 60 to 80% could be obese from different studies when they're admitted. So they're already insulin resistant. They may have an unknown pre-diabetes or even unknown diabetes. And this is just pushing them over the edge.
Let's continue on diabetes and then we'll shift to obesity. So we keep it clear, and even though there is overlap between the two diseases. So David Hopkins, if you have to give an advice about medications that might be particularly useful in the context of somebody developing severe COVID and diabetes, or medications that could actually be potentially risky, what would you say is, based on current knowledge, is the safest way to go?
So first and foremost, and primarily insulin. And the fact is, one thing we found in practice is that we put everybody on insulin regardless of the degree of severity in the acute phase. We've been very concerned about metformin because the vast majority have some degree of CKD. And actually, we've also seen very high lactate levels in quite a few people with new onset diabetes and COVID, even without prior exposure to metformin. So certainly in the acute and post-acute phase, we're being very cautious with that. SGLT2s we've been considering fairly well completely contraindicated. And indeed, in our type 1 practice, we've been proactively withdrawing SGLT2 because of concerns about risk of COVID and sudden decompensation with ketosis. Just one point about some of the new people that we're seeing is this issue of extreme diabetes and insulin resistance doesn't always seem to match the degree of severity of the COVID inflammatory response. So we've seen a few people now who've had profound dysglycemia, who have actually had a relatively short course of COVID. They've still had severe disease. They've been hospitalized, but they've actually recovered reasonably well and quite quickly and not required ITU management. Yet they've still had extremely high blood glucose, extremely high insulin requirements, which have been quite transient. And interestingly, these people appear to still have, well, they appear to have beta cell function well preserved because their insulin requirements drop very rapidly. But there's some odd disparity here to say that it's not just pure extreme inflammatory response that's driving the dysglycemia.
Thank you, David. Stephanie, as we overlap from diabetes and obesity, now we saw already that there is a link, clear link between obesity and COVID, between diabetes and COVID. If you take this from a general practitioner point of view and you face patients that are probably legitimately alarmed and worried because they hear the news every day, that they're a super risk of having very bad COVID. What would be the kind of advice you can give to patients to say, is there any way, anything I can do to mitigate my risk as a patient with obesity, as a person with diabetes?
I think with patients who have obesity and are living with obesity, I think it's very difficult because we know that there isn't an easy, quick answer to managing that. And so one of the things that I've been trying to do for my patients who I've diagnosed with COVID who have obesity is to reassure them that, yes, the statistics are a little bit worrying, but that, like anybody else, the vast majority of them will be okay. And I'm absolutely not advocating suddenly changing diets or rapid weight loss or any of those things, because I think that's just going to potentially cause people to become more unwell quite quickly. And I don't think that's a very sensible idea at all. One of the things then, and actually I'd be very interested to ask David, who was just talking, SGLT2s are something that we're sort of prescribing a lot in general practice and that we're sort of being told we should be doing. But now I'm wondering whether our patients who we diagnose with COVID in the community who aren't necessarily tested, but we are making a potential clinical diagnosis, which is the majority of our patients, whether we should be stopping them and whether we should be wondering and worrying about this, because it's not something that's being discussed very much. General practice in terms of the changes of our practice hasn't really been included hugely. And it would be really, really interesting to get some advice for myself and other GPs who might be watching, because I've been promoting this today for my GP colleagues, as to what we should do. I'd really like to know.
So we've got a very low threshold for stopping SGLT2. And anybody with actually proven or suspected COVID, we're stopping straight away, and we're also advising people accordingly. There's a bit of a question of how far you provide guidance, because clearly the vast majority of type 2 don't do any ketone testing, whereas obviously those with SGLT2 and type 1 are. But because we've seen now significant numbers of people with type 2 diabetes presenting with ketosis, we're universally stopping at the first suspicion.
Do you? Oh, sorry.
Go ahead.
I was just going to say, do we think that is as likely in the less unwell community cohort that we're dealing with? That's, I suppose, is my question, and I think you're going to answer that, Kamlesh.
I mean, from my point of view, I don't think we have the data to say that. So we're taking a potentially overcautious approach, but erring on the side of caution. I think Kamlesh wants to make a comment on that. Kamlesh?
Yeah, I think this is an interesting data. I'm just going to go on to metformin and then to SGLT2 inhibitors. So metformin data, there's just come out a study that's showing people who were on metformin already, before they went in hospital, they did well. They did better. And this may go with the pathophysiological mechanisms, how metformin works in terms of insulin resistance. But we don't know what happens once the patient goes in, whether they stop the therapy once the patient goes in. So there are caveats to that. But people who were already on it did better. In terms of SGLT2 inhibitors, again, I'm in two minds about it. A person who has severe disease, who's ketotic, we have to stop. And I think we should follow the sick day rules, because we don't have strong data yet that SGLT2 do harm or even possible benefits. There are potential mechanisms of how SGLT2 inhibitors do benefit patients from CVOTs, both in terms of myocardial and renal disease. We know 30-40% of people will have some sort of myocardial damage when they get COVID, and we also know possibly about 30% of people have AKI. And whether that's protected with SGLT2s, we don't know. So I'm a little bit cautious about stopping it from mild disease that continues. There is an international trial, DARE trial, that is testing dapagliflozin in people who are admitted with COVID over a 30-day period, in people with and without diabetes. And we'll find out in due course whether it is protective or safe in this population once they're admitted.
Thank you. Carol, you know that in obesity, we hear maybe far too often that a lot of the discourse is around the BMI, the weight itself, and there's weight-centric discussion, etc. And we agree, many of us agree, that in reality, obesity is more of a metabolic disease than an issue of being too heavy or an issue of mass in itself. But don't you think that perhaps, paradoxically, in this particular situation of COVID-19, the respiratory dysfunctions that are borderline in many people with obesity could become a particular problem from a mechanical standpoint in the course of severe pneumonia and severe illness like in COVID? Do you think that might play a role? We've heard from Ab that there is a lot of other things, molecular mechanism of all sorts, but what about the mechanics indeed?
Yeah, Francesca, I think you raised a very important point, that obesity has many complications, and we think of them as mechanical metabolic and also mental. And I think what we should think about the COVID-19 epidemic is how that impacts on all of these complications. Today, we're very interested in diabetes and the metabolic side, but you raise a very important point, the mechanical implications of carrying a large amount of subcutaneous tissue on your chest and almost having a restrictive lung disease also contributes to this. So you're correct. And this is just another example how we should not be focusing on BMI, but we should go beyond BMI and think about the complications of obesity and how other diseases like COVID-19 is impacting on those.
So that takes me to, for the sake of time, we will have to, unfortunately, stay on this level. We can't get any deeper, but this takes me to Barbara. Barbara, if respiratory dysfunctions may actually play a role in this, and is there a way to potentially use measures of these dysfunctions as a way to identify patients with obesity of farther higher risk of developing severe COVID or COVID-related mortality?
That's a very good question that you ask, and I'm not sure we have the answers for that, but certainly we can start to look into measures such as FEV1, for example, lung capacity, other respiratory measures, and try and see whether they correlate to outcomes, for example. I think, like I said, it's probably the mechanical side is definitely one of the things that we need to consider. Routinely, what we normally do with our patients, of course, they all have oximetry when they come, certainly into our tier 4 services, and that's to look for obstructive sleep apnea and to look for sort of obesity hyperventilation syndrome, which of course has a greater mortality, in fact a significantly high mortality. So it would be interesting to see perhaps whether in that cohort of patients mortality is higher and whether it can be predictive, but I'm not sure that's been looked at specifically.
So because the time for the panel discussion for this first panel is now ending, I'll leave it to you if you want to add anything, or you will get the opportunity, you can start introducing Barbara indeed for the next talk.
Absolutely. Thank you very much, Francesco, and thank you all the panel members for this great contribution. I very much enjoyed that.